Okay, for the case 3, which is not a really long case, the pulmonary infection is a tuberculosis. This is a 45-year-old woman, previously healthy, and she has no underlying disease. Her chief complaint was the non-productive cough for 2 weeks. She came to the hospital with the symptom of non-productive cough 2 weeks after returning from a vacation. The symptom persisted for about 2 weeks without improvement, and she also has malaise, difficulty in breathing, and anorexia and weight loss for 2 kilograms during the 2 weeks of sickness. And she has no fever, no headache, no autopnea, no dyspnea, and no rash. Just the non-productive cough and feel lethargic. For the past history, she has no underlying disease, as I mentioned before, and she refuses alcohol drinking, and she's a non-smoker. So for the question 1, uh, what is the additional history you would like to ask for uh, getting the diagnosis? You want to ask about the tuberculosis in her family, or the sexual history and partners, uh, or the travel history and your exposure, or you're going to ask all of them? Okay. If anyone want to, oh my God. So asking question doesn't cost anything, right? So, but you, okay, they have some, someone asked the tuberculosis, travel history, and exposure. Anyone want to share your idea or your thought, what you think are the most in this patient? You can use the microphone up there. All right. So, about 90% of you ask everything. Okay. Tuberculosis, sexual history, travel, animal. Okay, we move on. So she had no history of tuberculosis in her family, and she's single and refuses having multiple sexual partners. She's not taking any drug. She has two cats at home. She hid in a forest in the southern Thailand 2 weeks prior to the symptom. So any idea? Okay. So physical examination shows she had low grade fever, the temperature 37.7, respiratory 22, and the rest seemed to be quite normal, except that she had the crackles over her chest, uh, abdomen, and neuro, everything normal, but the lung size seems have some crackle over the chest. This is the chest X-ray and CT scan. Um, some of you already know, very familiar, especially someone who came from Malaysia. You have a lot of cases, right? I'm not sure. Really? Okay, just X-ray show bilateral uh, small nodules, look like it's some similarly, and also the CT scan, and you can see some the nodule all over, scattered over the lungs. And from the CT scan, I did not show here, the abdominal CAT scan also show the left adrenal gland enlargement about 0.5 to 1 centimeter, and also splenomegaly. So now, what is the most likely diagnosis? So tuberculosis is quite common in our region, don't forget that. Okay, what is the most likely diagnosis? Tuberculosis, histoplasmosis, cryptococcosis, tuberculomycosis, or cancer? So histoplasmosis 75%, tuberculosis, crypto, but cryptococcosis, um, I'm not sure to have the lung lesion like this. Not that very common. It's still possible. Histoplasm. Okay. So the next question, um, what is the laboratory test should be sent for the diagnosis? Sputum acid fast stain and culture for microbacteria, sputum culture for fungus, serum cryptoantigen, urine histoplasma antigen, and serum calyptomanin. But I don't have the choice all of them. I thought you might say all of them. Just one. It depends on what is the most likely diagnosis. Oh, interesting. You see, urine histoplasma antigen, sputum culture fungus, 16%, mycobacteria, cryptococcus, and calyptomanin. Okay, that's great. So most of you will send the urine cryptoplasma antigen. So in this patient, the anti-HIV was non-reactive because she has a prolonged fever, low-grade fever, and weight loss. So even though she doesn't have any risk for HIV, but we should check that. Sputum acid fast stain negative, and the culture for mycobacteria and fungus are still pending. Serum cryptococcal antigen was negative. Serum calyptomanin was negative. She underwent bronchoscopy with bronchoalveolar lavage and transbronchial biopsy. And this is the tissue from the lung. The pathologist reported she had a necrotizing granulomatous inflammation, but no acid-fast bacilli was found in the tissue. But instead, the GMS staining found something like this at the arrow side, no malignancy. So anyone has an idea? I have no choice now. So what is this? The budding yeast like histoplasma, right? So we have to wait for the culture. Yes, you can see the tuberculated conidia from the culture that grew in the lab. But someone who attend the wet lab this morning should be able to recognize this, right? Okay.
Can it be Cepedonium?
Wow, I don't know. You ask someone, the
No,
mycologist. Yeah.
microbiologist. Can it be a Cepedonium? Is there. That's the very important one. You
Okay.
know, in case of this tuberculate macroconidium, can be in case of Cepedonium, in rhinospora, this can be similar presentation. You should not identify immediately saying histo unless you see the microconidia is being present. You see, these are the macroconidia, and microconidia is here. And microconidia is less than 5 micron in structure, which can reach to the alveoli and produce the lung infection, not the macroconidia which produce the lung infection. So that's the very important for the microbiologist to diagnose it as histo. Don't go immediately with tuberculate macroconidia and say it's histo.
Okay, thank you. Uh, we have learned a lot today. Okay, so what is the diagnosis? I think we don't need the poll anymore. So it's a histoplasmosis. Okay, right. I just skip that. So the urine histoplasma antigen test turned out to be positive as well. Okay, and what is the most appropriate treatment if you see this patient? Okay, amphotericin B, amphotericin B plus fucytosine, fluconazole, itraconazole, voriconazole. Okay, most of you use the amphotericin B. Someone start with the itraconazole. Okay. Okay, in this case, it depends on the severity. So we can, if in the severe case, we should start with amphotericin B for induction for 1 or 2 weeks, and then change to itraconazole for a mild, not the severe case. We can start with itraconazole. So in this case, actually, she had a travel history. 2 weeks before the symptom developed, she traveled to the south of Thailand within the group, and she went into a tree hollow. Inside the tree hollow, um, here, to see something inside. I'm not sure what's interesting inside. But once they came back, about 7 of the 10 developed symptom. So this is one of them, but not only one, because most of them have this symptom. And in these three hollow, they have the bat, the lesser fall vampire bat. This is the scientific name. Okay. So this cat is the histoplasmosis. If you look at the geographic region of histoplasmosis, this is the endemic mycosis, uh, prevalent, mainly prevalent in the United States, in the Midwest area and the South America here, but also in the Africa as well. This is the African histoplasmosis. But the data in our region, in Southeast Asia and Asia Pacific region, is lacking. I see we don't have like a big data to show where we have more histoplasmosis cases. Only some reported case and case series in this area. Yeah. Uh, so this fungus had 5 clades. So it's a clade, the class 1 and class 2 was the North Americans, and also there are some classes belong to the histoplasma capsulatum duboisii that cause the African histoplasmosis. That actually we in Thailand and also in our region we have seen most of the cases related to HIV or advanced AIDS. But in the endemic area, like in the America, they are also seen in the immunocompetent host that can cause acute pulmonary histoplasmosis. So this syndrome had the incubation period about 14 days and can be asymptomatic, or it occur like a flu-like illness, has fever, headache, non-productive cough, and also they may have the extra pulmonary signs and symptoms such as arthritis, erythema nodosum, and the symptom can be resolved spontaneously in 10 days without any treatment, and more than 90% may be unrecognized. And the chest X-ray may show mediastinal or lymph node enlargement, patchy infiltration, or calcification. Some cases may mimic tuberculosis, like our case. It can be like had a cavity in the lung. The patient may have low-grade fever, weight loss, productive cough, dyspnea, hemoptysis. And the chest X-ray may show the cavity or patchy infiltration or consolidation. And some of them may not have cavity, so it's non-cavitary chronic pulmonary histoplasmosis. This sometimes we have to make a we may misdiagnose to be tuberculosis. However, the most common syndrome that we have seen uh, is a progressive disseminated histoplasmosis that can present with the multiple organ involvement in the chronic form, with the patchy pneumonitis, lymphadenopathy, and may have the cytopenia from the blood smear, CNS involvement, endocarditis, adrenal gland involvement, like in this case as well. So this is our case with adrenal histoplasmosis. You can see the adrenal gland here, enlargement bilaterally, and also the oral lesion can be something like the closed lesion and in the tongue, in the mouth. This is also the clue for us to think about the histoplasmosis. Yeah. So for the treatment of disseminated histoplasmosis, the recommendation from the guideline suggests to use the liposomal amphotericin B at the dose of 3 milligram per kilo daily. That has shown to be superior to the deoxycholate in HIV patient with disseminated histoplasmosis. After successful induction therapy, we can use itraconazole for at least 1 year. in less severe disease, itraconazole can be initiated. Fluconazole has a lower success rather than the itraconazole, but it's not recommended. Voriconazole is also not a routinely recommended. Okay, and also histoplasmosis secondary to the TNF alpha inhibitor therapy. We need to discontinue the TNF alpha blocker during the antifungal therapy. And antifungal treatment should be administered for about 12 months. And if possible, we should send the urine antigen test to make sure the antigen was negative. Okay. So the take-home message is the pulmonary histoplasmosis may mimic pulmonary tuberculosis, and it can occur in non-HIV patients. The history related to the exposure is helpful for diagnosis. In particular, the history that exposed to the bat or bird or going to the forest. The fungus is slow going and can be missed if a fungal culture is not requested or doesn't go incubate for long enough. Okay. So I would like to acknowledge Dr. Manu Lichweng-Mong, who this case belong to him, and he is the president of the TMMF. Okay. Okay. Thank you very much.